Welcome back to the ACP web broadcasts. We're now going to have a breast session, and I've got David Miles and Carlo Palmieri.
So the first study we're talking about is a clinical and translational results of CALGB 40601, which is a Neo-Adjuvant phase 3 study looking at weekly paclitaxel and trastuzumab with or without lapatinib for HER2-positive breast cancer. So the study took stage 2 to 3 early breast cancer, randomized them to 3 arms: paclitaxel with trastuzumab, paclitaxel with trastuzumab and lapatinib, and trastuzumab, and a third arm of paclitaxel and lapatinib, which was subsequently closed early because of lack of efficacy and toxicity. The primary endpoint was determining if PCR was 20% or greater with a dual blockade as compared to trastuzumab with paclitaxel. And the assumption was that the PCR rate in the trastuzumab and Herceptin arm, or trastuzumab and paclitaxel arm, would be 30%. So the top-line results are that in the paclitaxel and trastuzumab, the PCR rate was 46%, and in the paclitaxel, trastuzumab and lapatinib arm, 56%. This wasn't statistically significant. In those patients who entered the paclitaxel and lapatinib arm, the PCR rate was low at 37%. As you can see from the toxicities, they're probably what one would expect based on the prior studies. You can see that the diarrhea grade 3 rates are higher with the addition of lapatinib in both the combination arm with trastuzumab and alone with paclitaxel. As one would expect, trastuzumab was well tolerated with very low grade 3 toxicity. So what does this tell us? There's no statistical significant difference between adding in a doublet as compared to single agent trastuzumab. The results are similar to those published in prior neoadjuvant HER2-positive studies. In particular, the PCR rate was higher in the hormone receptor negative group, seen in the previous studies as well. And currently there are tissue-based studies which are using these tissues to look at potential predictive markers of those who may benefit from just having one of the HER2-directed agents. The second set of slides are a follow-on from the first study. This was a presentation by one of the surgeons involved in CALGB 40601, and this is looking at the conversion rates between those who are considered not eligible for breast conserving therapy prior to starting the neoadjuvant therapy, and the conversion rate to eligible for BCT after treatment. Based on the surgeon's assessment at the start of treatment, 42% were considered candidates for breast preservation, and 58% were not considered candidates for BCT. After the neoadjuvant therapy, 94% remained candidates for BCT, while 43% were assessed to be candidates for BCT who prior to the neoadjuvant therapy weren't considered candidates. And as you can see, a small proportion actually became ineligible for breast preservation following neoadjuvant therapy. This summarizes the PCR rates based on whether at the start of treatment they were eligible for BCT, and then following the neoadjuvant therapy, whether they were then considered eligible or not for BCT. And in essence, the take-home message from this slide is that we're very poor at predicting the PCR rate based on clinical assessment. As you can see, 44% of those who were not considered eligible for breast conserving therapy actually had a PCR within the breast. And there's no statistical difference between those considered eligible or not eligible for BCT for the PCR rate. So the key message, 43% conversion from ineligible to eligible for BCT in the HER2 positive. Where BCT was attempted, 80% of patients successfully attained this. So the surgeons, where they did it, were quite good at doing it. Now I'm going to hand over to David Miles, who's going to take us through the next 2 sets of slides. David.
So in terms of primary therapy for HER2 positive patients with HER2 positive disease, we move on to the ASCO study. This was presented by Aman Bozdar, and those of you who are old enough will remember that Aman Bozdar presented the Neo-Adjuvant data from the MD Anderson, the first trial really with Herceptin, looking at FEC and a taxoid-containing regimen. It was a very small study, and actually they stopped it early because the path-CR rate was very high. What is interesting about this trial is that it seriously addresses a clinical point that troubles us. And after the presentation of this, I think we can cease to be quite as troubled as we were. Let me explain. Arm one of this, so in both arms of this study, there was trastuzumab, Herceptin was in there. Arm one of the study was FEC, followed by Taxol with Herceptin. This is, I guess, very much what we do in the UK. The experimental arm, if you will, was this concept of putting the taxoids first and running the Herceptin right through the taxoid and the anthracycline. And in some respects, I think we've been a little nervous about doing that because of potential cardiotoxic interactions between Herceptin and the anthracycline. As it happened, they use a relatively relaxed dose of anthracycline here, 75 per meter squared. So again, something that we're probably more used to in the UK. So from an efficacy point of view, what you can see here is that the pathological complete response rate, whether it's in breast or in breast and lymph nodes, is actually very similar in the two arms of the study. So the path-CR rate is high. We knew that was going to be the case from his initial studies, from many other studies as well. But the important point here is that there seems to be no difference between the two arms of the study, no matter how you score path-CR rate. Predictably, perhaps, there was a little more in terms of toxicity when the taxoid was used first with trastuzumab right the way through. So you can see there are a little bit more neutropenia, fatigue, and potentially neurosensory problems. One thing that isn't presented on this slide, which is very, very important, is, of course, the cardiac toxicity data. And that was something that was presented the day before in a poster discussion session. And the take-home message from that, which should go on this, be considered with the key messages here, is that there was no difference in cardiotoxicity. So in some senses, that is reassuring in terms of saying, you know, here is a regimen that we could use that doesn't cause much in the way of increased cardiac tox. But in fact, the key message, I think, is that when you look at the path-CR rates, we're probably just as well doing what we do already, which is FEC first, taxoid with the HER2-directed therapy. So I think that's not taking the field much further forward, but in some senses reassuring what we do already. There then followed a follow-up from, of course, Luca Gianni's NOAA study. And this was, of course, again, one of the pivotal studies that looked at neoadjuvant Herceptin with a fairly hefty chemotherapy regimen, as far as I remember. And this was looking at the contribution of Herceptin as a whole. And of course, it's a relatively small randomized study in that sense, neoadjuvant, of course, but important to remind ourselves and remember these were patients with quite a burden of disease, not just big tumors, but actually included inflammatory cancers as well. So quite a challenge in terms of treatment, as we know. And just reminding myself from some notes here that the path-CR rate, which isn't on this slide, but the path-CR rate in the Herceptin-containing arm was 43%, compared with 22% in the arm that didn't have Herceptin in it. And thinking about a 43% path-CR rate for this group of patients with very big tumors, many of them with inflammatory disease, is a pretty impressive outcome, I would say. And backing up very much what Luca has suggested in the past, that this ability to achieve the path-CR is translating into a better event-free survival at 5 years. So you can see there a hazard rate of 0.64. And so this is a very significant result in terms of event-free survival. And obviously those with path-CR, you know, that's accentuated as well. So a big improvement in event-free survival in that group. The overall survival, I mean, I think it would be kind of churlish to suggest that, you know, that wasn't a a significant effect. It doesn't quite reach statistical significance, but I think, as ever, what it points out that with a targeted therapy, when you know the target and you've got a targeted agent, then you're seeing, it's very easy to see big results with a relatively small patient group. Again, making the point, on this slide as well, that the cardiac tolerability was good. So again, this was a regimen where the HER2-directed therapy, Herceptin, was really used throughout the chemotherapy regimen. So not much in terms of cardiac failure. But I think it's important to remember, not only from the NOAA study, but also from Ammon Buzdar's study previously, while we can be somewhat reassured by the cardiac tox, what we have to bear in mind is that the follow-up on this is relatively small. And in terms of longer-term cardiac toxicity, I think that's still an open question. So again, I think the summary from Luca's presentation of the NOAA study is that it really underscores the observation that have already been made. I'm going to have to go back and look at his presentation again, because I was getting somewhat confused about his interpretations of PathCR versus long-term outcomes, and a lot has been made about the association of PathCR with longer-term outcome and how the FDA might utilize this in terms of licensing and early licensing of products. But I think the thing that taxes Luca and team very much is this whole question about, when you don't get a PathCR, what is the nature of those cells that are remaining? And it's going to be very interesting to look at the phenotype of those particular tumor cells that are left. So I think we'll head for some discussion about these 4 presentations. So if we just thinking about those studies that we presented to you, we've got some of the neoadjuvant data in HER2-positive disease. And I mean, the CALGB study, just thinking about it, Carl, I mean, on the slide that we showed our colleagues here, that it just looked like a 2-arm study, but we have to remember that there was this third arm with lapatinib on its own, I guess very much as a result of the Neo-Alto study. The decision was made to lose that arm early. But we still got this comparison, I guess, Absolutely. Of the dual versus a single blockade. So,
and that's partly because of toxicity as well as the efficacy issue. And the efficacy issue may have been because of the toxicity issue.
Yeah, sure. So I mean, this is very much a reflection of the B41 study, really, isn't it? So there's this, this small increase in PathCR that doesn't reach statistical significance, but you realise, biologically there's something, there's something going on there. And actually, there was a really good summary at the end of this session on, the whole dual blockade piece with. Neosphere, so the pertuzumab story obviously as well.
And the other issue is whether there's enough patients in the study to show a difference. There's only, 118, 120 each arm?
Sure.
Quite small, isn't it?
Sure. So I guess it's, I mean, to say more of the same sounds a little bit cruel, but in some senses, I guess that's what we are looking at. I guess it underscores the fact that we're waiting with bated breath for the adjuvant trial. So we've got the neoadjuvants with pertuzumab, we've got the neoadjuvants with lapatinib, of course, and we're really just waiting pretty much with bated breath to see what happens in terms of the true adjuvant setting.
Although the dual blockade does have a numerically higher PathCR rate, so...
No, sure, absolutely, and I think it's important to note. I mean, coming on to the surgical aspects of this, so it was quite interesting actually, because the surgeons seem to be completely delighted to be involved in this study. He just kept thanking people for having the surgeons involved, which I think is
Exactly.
I think it's the way that it should be, clearly. I mean, I think there were really several. I've always find these discussions quite difficult because the denominators change, and I get instantly very confused.
It's very easy. We're only medical oncologists.
But I guess the key points were, for me, that for those patients in whom they thought breast-conserving treatment wasn't going to be possible, then perhaps as a result of improving responses, 40-odd% of patients were converted to breast-conserving treatment potentially.
Yeah. And also, it's quite high. 6% became ineligible.
Yeah.
We don't often see it clinically, do we? So.
Well, I guess maybe we don't admit to it. So Carl was
true.
just talking about the fact that 7 patients who were initially thought to be suitable for BCT actually weren't by the time they'd finished the treatment. I guess the other key point for me, and Monica Morrow brought this up the day before as well, there's a lot more mastectomies going on in the US than in the UK. And in this situation, actually, although a lot of patients were eligible for BCT, it was clear that actually many patients, for whatever reason, just went straight for mastectomy.
Absolutely, who were preservable, absolutely.
Anyway.
Which probably reflects clinical practice as well.
Well, I guess so, or risk evaluation
by the patient.
Risk evaluation by the patients. And then, as you said in your description, I think the point was that either clinically or radiologically, it was actually impossible to work out who was going to do the BCT, how you assess that before the operation. Actually, Matt Ellis got up in the discussion and talked about, almost doing a diagnostic excision biopsy. There was some pushback on that, and then Matt instantly pointed out the number of times that patients could be going back for multiple surgeries if they had reconstruction.
Yeah. It creates problems if it's a multicentric tumour, and then what do you do? Do you have to then sample those and margins? Sure. And so, but it's a new way of looking at things, whether we should be doing that.
Yeah.
But they're just presenting the same challenges.
I think it was a good presentation because they also listed why BCT wasn't possible.
Absolutely.
And in some senses we think we know what the answer to that is, but it was nice to see them sort of in ranked order.
Yeah.
So I think it's worthwhile people going back and looking at that presentation because it had a very sort of practical feel about it, which I thought was
and in a way reflects clinical practice. It was actually surgical assessment, which way they went, actually quite a practical bit of the study actually, and clinically meaningful.
Yeah,
and very simple to do as well.
It ought to be. There were questions about MRI in the discussion session as well.
But he seemed to be holding back because there's other data to come, so they're obviously not cooked all the data yet.
Yeah, I guess so. But no, I thought it was a worthy combination, really, of the systemic stuff versus the surgical.
And it's nice to let surgeons present an oncology meeting.
Yeah.
We're very giving.
Absolutely right. So if we think about Aman Bozdar's presentation.
I thought he'd retired.
Well, clearly not. So what was your take on this?
Well, in essence, that, as you said, it doesn't matter where we put the trastuzumab. If we put it with the anthracyclines or start it after the anthracycline with the taxane, the path-CR rate is the same. So as you probably quite rightly say, the safety follow-up data isn't there to say that actually giving FEC and trastuzumab long-term. And if you look at the overview data of the effect of anthracyclines on the heart, there's clearly a long-term issue, 10, 20 years out. So who knows how potentially the trastuzumab may influence that. So as you quite rightly said, I think if the path-CR is no difference, safety should be probably put first, and we should probably do as we do at the moment and keep the tras to start when we start the taxane. I think it's reasonable.
Do you ever use it with the anthracycline?
No.
Or you've kind of, I mean, I have to say I've veered away from
absolutely.
it. Really.
The only advantage for the patients is it gets the trastuzumab, the year the trastuzumab started, therefore finished earlier. But I mean, one needs to put it in context of the safety issue. I mean, if we haven't got that safe data, I think and there's no difference to the path-CR, then I think that we should keep doing what we're doing at the moment.
Yeah.
So it's a useful study in that it tells us what we're doing actually is okay.
Yeah. The other thing that actually was brought up during the discussion, of course, was relating back to dear old Neo-Tango and this whole scheduling of the taxoids. The suggestion if you started with the taxoids first and followed by the anthracycline, that somehow things would be better.
Yeah.
And in a way that this study also puts that concept to bed slightly.
Exactly.
So, I think I came out of there thinking this was sort of pretty reassuring that what we're doing is actually okay.
Okay, absolutely.
And there was nothing about this that would make one particularly want.
And as Bozdar said to that question, you can find evidence for whatever you believe in.
Exactly. And I thought that was a good and a wise point from him. So I mean, then thinking about the NOAA study. So
interesting. So basically, one needs to remember in the NOAA study that this study was done at a time when trastuzumab was not licensed. So one needs to bear in mind in that chemotherapy arm 2 that approximately 16% of patients got the tras after their surgery when the drug was licensed. So one must remember when it looks at the survival data that these patients did not get what can be considered now standard of care. And it showed essentially that those who got the Herceptin with the chemotherapy up front in the neoadjuvant setting did much better. The other thing is that the PCR in the chemotherapy arm alone didn't predict for outcome or was poorly predictive of benefits. So that's interesting. Why in chemotherapy in HER2 positive, if you have a PCR, you don't do as well if you have a PCR with chemotherapy and Herceptin. So what is that telling us?
Well, that's where I was finding it difficult to interpret his interpretation
Absolutely.
of it, really.
And it's very difficult in an initial 15-minute presentation. You take the data in.
Yeah.
So that's the other issue is actually what chemotherapy, if you're HER2 positive, you get PCR, may not be as good as if you're HER2 negative and get a PCR. So what does that mean biologically? I'm trying to get my head around it.
I think the other thing worth pointing out from just about all the studies we've discussed is that while the presenters all did ITT presentations, many of them also predictably did it by hormone receptor status.
Absolutely. And the other point we haven't shown is the outcome side, but if you even look at the outcome side of the overall survival in the chemotherapy and Herceptin arm, they weren't doing brilliantly. There was like, 60%? It was the curves were...
Sure, they were, but then that goes back to the point I was trying to make, that these were big tumours and patients with inflammatory disease. This wasn't your kind of normal neoadjuvant.
But it makes these studies that we're now doing with adding in therapy in those with residual disease, with Herceptin in the adjuvant setting, relevant. So potentially tells us that actually we can gain by adding in additional HER2-directed therapy, potentially those who have residual disease, or I'm not sure how many, even potentially if they have a PCR, but so it looks like we need more HER2-directed therapy in those with big tumours and residual disease.
And residual disease. And then that also makes the point about in those patients where you do get a really good path-CR in breast and nodes, how much more of anything do you need?
Absolutely.
So I think we need to be dividing up those populations. You're right, and of course there's a proposed TDM1 study for those who have HER2-directed therapy and have a lot of residual disease at surgery, because that's obviously a sort of low-hanging fruit.
Absolutely, but also I can't recall what the overall survival in those who got a PCR at 5 years was. So even if you have a PCR in the adjuvant setting, you've still got a big high-risk tumour. Would they gain anything from add-in therapy? I mean, that's the only other thing. But I can't remember what their overall survival was compared to those who didn't from the slide.
Not great.
So it may be that even those big tumours, or do we need to give everything up front? Is it better to basically get a PCR and by throwing everything at the tumour up front, or try to select those, just give trastuzumab and then wait for the pathological specimen if they've had a PCR or not? So these are sort of questions that remain unanswered.
And I guess the other thing to say is throughout all of these, there was the correlative biomarker stuff that will follow.
Exactly.
To what extent that will ever really, truly help us, is
I agree.
Debate,
I think we've not got there quite yet.
But no, I think as a session, dual blockade, we know that's a good thing. I think a lot of reassurance from UK practice that actually what we're doing is okay right now.
Absolutely.